now. So what was the need for updating this FIGO staging of endometrial cancer? Anybody? Why was it updated in 2023? Was it really required? Yes or no? No one wants to talk now. So basically, we had updated, there was a need for updating this, the FIGO staging of endometrial cancer because we used to rely more on the anatomical staging before. So now the histopathological type of the tumor becomes the central feature to all of your endometrial cancers, the staging, the treatment, everything is being decided on this histopathological diagnosis, and the post-operative treatment depends on the molecular typing. That's why they came up with this a bit complicated, but if you go through it, it actually makes a lot of sense in here. So when we talk about the stage 1, it's almost remains the same. Even before we had stage 1A, 1B, 1C, but it was very superficial. We used to say, like, is it limited to the endometrium? Then it is 1A. If it is, more less than 50% of myometrium involvement, then it's 1B. Then 1C was like more than 50% of myometrium. But now it is bit different. So if you look at it, that we are more worried about the grading or the aggressive and non-aggressive histological types in here. So up till almost 1B, okay, it's always non-aggressive histological types. So what is non-aggressive histological types they are talking about? So remember, non-aggressive histological types are your endometrioid endometrial cancer. So in the exam, you have to look out that what is the histological type of the cancer that they are talking about. If it is endometrioid endometrial cancers, then it has got 3 grades. Grade 1, grade 2, grade 3. It is depending upon how much is the solid component in the tumor. Is it less than 50% or is it 60 to 50% solid component or is it more than 50% solid component? You don't need all of that. But is it grade 1 and grade 2? Then it is the low grade cancers. That means it's a non-aggressive histological types. The moment you see grade 3 or a high grade endometrioid endometrial cancer, it becomes aggressive histological type. So endometrioid endometrial cancers, we are grading them and then we are putting them into non-aggressive and aggressive. However, the other types, other histological types, be it serous, clear cell, mixed, undifferentiated, carcinosarcoma, these are inherently aggressive. This doesn't require any grading. So the grading is applicable only for your endometrioid endometrial cancer. So if they give that, naturally which grade is also important to put it into the staging pattern. Okay. So your serous cancers, clear cell cancers, all these cancers are naturally aggressive histological types. I hope this is clear so far. So 1A and 1B are non-aggressive histological types. That means it has to be a low-grade cancer like grade 1 and grade 2 endometrioid endometrial cancers. And if it is only limited to the polyp or it is confined to the endometrium, then it is 1A1. So always start from inside and then move outwards. Okay, so first start with a polyp or an endometrium, then you move towards myometrium, then you move towards the adnexa serosa, like that. Then your staging becomes very, very easy. So 1A1 is, it's a non-aggressive histological type, but it is limited only to the endometrial polyp or endometrium. Whereas 1A2 is a non-aggressive histological type, which is involving less than half of the myometrium. And whereas 1A3 is, it's a low-grade cancer again, it's the same non-aggressive histological type, whereas it is limited to the uterus and ovary. This is the special category that they have added, which is 1A3. So I'll discuss this in detail later. Just concentrate on 1B now. This is also non-aggressive histological types, but it's more than or more or equal to half of the myometrium which is involved with no or focal lymphovascular stromal invasion. The moment it is aggressive histological type, then you have to rule out whether it is 1C, okay, whether it is 1C or whether it is 2C. If it is 1C, then the tumor is limited only to the endometrial polyp or to the endometrium. Aggressive histological type. It could be your grade 3 endometrioid endometrial cancer or any other histological types for that matter. But the moment it says aggressive histological type, but it is not only limited to the endometrium. There is some amount of myometrial involvement is also there. It could be any percentage, 10%, 20%, 60%, any percentage. So the moment you see that, it becomes aggressive histological type with any myometrial involvement. So that is the difference between your 1C and 2C. 1C is where it's an aggressive histological type. 1C and 2C both are aggressive histological types, but is it limited only to the endometrium or is it with any myometrial invasion? That is the difference. This is how we have to differentiate and remember it. Stage 2 is again easy. It's the same thing. 2A is where cervical stromal involvement will be there. Stromal involvement, okay, it has to be a stroma, not the glandular component. Okay, cervical stroma, it has to be a deeper invasion. Stage 2B is where substantial lymphovascular stromal invasion. If it is so focal, we ignore. It comes under stage 1 cancer. Substantial lymphovascular stromal invasion means there are some lymphatic channels, okay, which are close to the cancer cells, which are basically get involved by the cancer cells. So when there's a 5 or more lymphatic channels are involved, we call it as substantial. You don't have to remember about how many lymphatic channels, but if it's substantial lymphovascular stromal invasion, then it becomes stage 2B. Understood up till now? Everybody? Yes or no? Please keep answering. No, don't put it in the chat box. Please answer. Because I can't keep. Okay, where is it? Yeah.
Yes, ma'am, very clear.
Just, yeah.
Yes, ma'am, clear.
Yeah. So when it comes to stage 1A3, remember 1A3, and if you make it just the opposite, it becomes 3A1. So when it comes to endometrial cancer and ovary, it's always important for us to differentiate between is it 1A3 or it is 3A1 stage. So how are we going to differentiate? So this is an additional, the stage that, that they have created. I'll tell you the reason. Because they started doing for an early cancer, the treatment would remain total laparoscopic hysterectomy with bilateral salpingo-oophorectomy. So when they removed the ovaries, they started seeing some cancers on the ovaries as well. And if you have seen them clearly on the microscope, they were almost clonally related. So they started wondering, is it a metastatic cancer to the ovary or is it two different independent cancers, two different primary tumors which is arising from the ovary as well as from the endometrium. But then later they understood that they were clonally related, so the cells were almost similar to the endometrial cancer. So they started, because they had a good prognosis, they did not want to put it under 3A cancer. Okay, stage 3A cancer. So that's why they started understanding that they behave well. So why should we put them under stage 3 cancer when they are actually very low grade cancers? But how are we differentiating that? How are we saying that this is a 1A3 cancer but not 3A1 cancer? So you need to look at it that basically one ovary should be involved, and it should be low grade cancers, low grade endometrial cancers, and invasion should be less than 50%. Myometrial invasion should be less than 50%. Okay, and the capsule should be intact. There should not be any breach in the ovarian capsule. So once we get these checklists done, then they started grouping them under 1A3. If any of these do not match, say for example both the ovaries are involved, capsule has been breached, okay, and it's not a low grade, it's a aggressive histological type, and myometrial invasion is more than 50%, then naturally it shifts the upstage the cancer from stage 1A3 to stage 3A1, where it's a proper adnexal involvement. It's basically a metastasis. But if you have got low grade cancer, less than 50% myometrial invasion, only one ovary is involved, it's a low grade cancer, okay, then yes, it's only 1A3, which is actually a very early cancer, and the prognosis is better. Okay, so remember 1A3 and just make it opposite, it's a 3A1, how to differentiate both. Understood? Clear, everybody? Clear, guys?
Yes, yes.
Perfect. So, and then stage 3 and stage 4 would remain I mean, it's almost the same. It's just that 3A is bit, 3A is where that I just discussed. 3A1 is where there is a spread to the ovary and, fallopian tube as well. And whereas 3A2 is where the involvement of the uterine subserosa always move outwards. Okay, it's endometrium. Serosa is the only difference. So endometrium or a polyp, then myometrium less than 50%, more than 50%. And then you mention about the ovary. Okay, and then you talk about the cervical stroma and everything. And then they move even more outwards, like adnexal involvement. And then they move downwards, involving the vagina parametrium. So have this mental mapping in your head and practice it a couple of times. Then it becomes very easy, the staging. You can always crack it out during your exams. And whenever there is a metastasis to the lymph nodes, then it becomes stage 3C. So wherever you see there is adnexal involvement, except that 1A3 I talk about, or they mention subserosa, uterine serosa is involved, or vagina is involved, parametrium is involved, or lymph nodes are involved, or pelvic peritoneum is involved, then they all come under stage 3. Okay, even if you don't remember 3A, 3B, 3C, which you are not going to explain it to a patient in detail. So just remember, if these organs are involved, then it comes under stage 3. And stage 4, of course, it's going to be advanced cancer involving the bladder mucosa, bowel mucosa, and it goes beyond the pelvic peritoneum. All the abdominal mets will be there, abdominal lymph nodes will be involved. Okay, so this is all about your the staging. So this I've tried to simplify as much as I told. So why the myometrial invasion is so important? Okay, why are we talking about it? Is that the more and more it goes outside the myometrial invasion, there's a greater chance that lymph nodes can be positive. There's a greater chance that the stage can upstage, and there's a greater chance that it can come back. So that's the reason that why we are worried about this one. Okay, so always remember what is the difference between 1C and 2C. It's only both are aggressive histological types, but it is limiting to the endometrium or endometrial polyp, then it comes under 1C. But if it is already having some myometrial invasion as well, then it becomes 2C. Okay, and if they mention no or focal lymphovascular stromal invasion, you can completely ignore them. But if they have got a substantial lymphovascular stromal invasion, then it becomes stage 2, which is specifically stage 2B. All right. So adnexal involvement, I already told you that this is a special category that the FIGO has told, because they kind of behave well. Okay, the stage 1A3, they behave really well. So they did not want to put it under stage 3. So it's only stage 1. So especially when they have got low grade, less than 50% myometrial invasion, and no substantial lymphovascular stromal invasion, no other meds, and unilateral, only one ovary is involved. Tumor is confined to the ovary, no tumor breach, nothing, no capsular breach. Then it comes under stage 1A3. Understood how to differentiate between stage 1A3 and 3A1? Just the opposite. Clear?
Yes, doctor.
Okay, perfect. So because it has got a favorable outcome, we put it under 1A3. But if these things are not matching, like, it is not going in the direction of what I mentioned, bilateral ovary, deeper invasion, there's a capsular rupture and things like that, then naturally it becomes 3A1. It has got an extensive, the metastatic spread there. So again, the fallopian, this is an additional FIGO staging. The modification, the update that has come up is that before we used to take it as peritoneal washings also into the account of staging. Okay, but now we are not considering that. Just because you've removed the fallopian tubes and inside you're seeing some cancer cells, they're floating inside the lumen, it doesn't mean that they have got stage 3 cancer. It could be just from the manipulation, surgical manipulation, or when you have given the wash or something that must have been spread across. But it doesn't mean that you are actually seeing that. So previously the peritoneal cytology washings were important, but now we are not considering it, and that doesn't alter your FIGO staging. Okay, but it still should be documented, but that's not important. So when the myometrium is only involved at stage 1, then you have to start thinking, is it aggressive, non-aggressive histological type? Is it only limited to the endometrium, or is it limited only to the myometrium? So you have to start thinking like that. If the cervical stroma is involved, naturally it becomes stage 2. If serosa or adnexa are involved, then it becomes stage 3A. Okay, any question? So the micromets and macromets are important because they come under stage 3B. But your isolated tumor cells I just mentioned, or the tumor washings, are not considered. They are not going to upstage your cancer. Okay, we are going to do some activity now. Before that, I just want to understand from all of you that you have understood the staging so far. Everyone, are you with me so far?
Yes, Dr. Deepika.
Okay, any questions from anyone? Dr. Maria, Kine?
Oh man.
Okay, perfect. So why has molecular typing now become extremely important in endometrial cancers? This we have already answered. That the molecular typing is extremely important because once we have this cancer being out from the surgery, it's important to do the risk stratification, whether they come under low risk, whether they come under high risk, whether they come under intermediate risk or high intermediate risk or a high risk. And based on that, we always suggest them an adjuvant treatment to prevent the recurrence and improve the overall quality of life. So it's important to know that molecular typing. Without that, it's very, very difficult. So if you have gone through the FIGO classification or ESGO classifications, you start noticing something like this. They write something like, say for example, you have got a grade 3 cancer. Okay, grade 3 is high grade endometrial cancers, right? So, and obviously it comes under 1C because it's a grade 3, which is a aggressive histological type, and it is limited to the endometrium or a polyp, so it comes under 1C. And they have done the molecular typing and it shows P53 abnormality. And we write this final interpretation as 1C molecular typing. M stands for molecular typing, P53 abnormality. If you have got a pole mutation, similarly, 1CM pole mutant. If you have got MMR deficiency, we started writing 2CM MMR deficiency. So this is how we have changed some annotations here. Okay, so if we have to look at it, the different risk groups, this I have taken from ESGO Estro guidelines, which has been updated in 2025, which is last year. So there is so much on this side. You can see that there is this anatomical staging 1A1, 1A2, 1A3, and they have given the description. Basically, you have got an anatomical stage as well as histopathological diagnosis there. It's a histopathological tumor type. And here on this particular row, we can see there is a molecular classification. We have got pole, we have got MMR deficiency, we have got NSMP low grade and estrogen receptor positive, we have got NSMP high grade estrogen receptor negative, we have got P53 abnormal. So, so many the molecular classification they have given. And other thing that you are noticing here is that color coding. There is green, there is gray, there is this red, there is this yellow, okay, there is this orange. So this is also the color coding that has been given here for this risk stratifications. Okay, this much you understood now? How to read this table? Guys, are you with me so far?
Yes, doctor.
Okay. So, if you look at this, why am I having this trouble? Sorry. Yeah. So, earlier understanding was that we knew the histological type, whether it's grade 1, grade 2, grade 3, aggressive, non-aggressive histological types, all of that. And we know the stage, anatomical stage, whether it is limited to endometrium, is it myometrial invasion, how much is the myometrial invasion, and then is it involving the ovary, is it involving the fallopian tubes, is it involving the lymph nodes. So we knew the anatomical stage and we knew the histological type and we knew the grade as well. These are the three things that we knew. And grade 1 and 2, we knew that it's a low risk, and grade 3, we knew that it's a high risk cancers of endometrial cancers. But now we realize that not all grade 3 cancers would behave the same. I mean to say, all this while we were thinking grade 3 means it's a high risk. They have a higher risk of nodal spread, they have a higher risk of recurrence, they have got a poor prognosis, they need adjuvant treatment, all of that. We used to think like this. But now they started understanding that some behave very aggressively, but some behave really well. If they have done the retrospective study or a prospective study, they understood like this, that not all grade 3 cancers that we used to label them as high grade, they behave the same. And they started saying that grade 3 disease is heterogeneous. This is only based on this that they started studying this molecular typing on those cancer cells. That's why they came to this interpretation. So if you have got, if they have got, so basically when it comes to the molecular typing, you have to remember only 4 to 5 things. Pole mutation, P53 abnormality, MMR deficiency, then NSMR, which has got two things, low grade, high grade, and then ER positive, which is estrogen receptor positive and estrogen receptor negative. So there are only 5 molecular typing that you guys have to remember. So if I have to give you an example, just look at this carefully. I want all of you to pay an attention now. All of them are grade 3 cancer, grade 3 cancer, grade 3, grade 3. But the molecular subtype was different from all the patients. One had pole mutant. Another had P53 abnormality. Other one had MMR. Similarly, NSMR ER negative. And if they looked at the behavior of the cancer, surprisingly, those who had grade 3 endometrial cancers with pole mutant, they had an excellent prognosis in terms of their recurrence, in terms of their survival benefit, all of that. Whereas P53 abnormal, those who express P53 abnormality, the cancer behaved very aggressively. And MMR deficiency, it is a bit paradox, we'll come to that later. And again, NSMR, where estrogen receptor was negative, they also had a poor prognosis. So some behaved really well, which had an excellent prognosis, but some behaved worst, like very aggressive or a poor prognosis. This is why they started studying the molecular typing in detail. Understood now? All of you? Clear up till now?
Yes, ma'am.
Dr. Nancy, Nazia, Soumya?
Yes, ma'am.
Okay, perfect. So all we have to remember is that now how to interpret. In the exam, we'll not be having so much of time to look at what is the anatomical stage, molecular subtype. But if you practice it a couple of times, it will come to you. It will become a cakewalk. So first is anatomical staging. You should be knowing. Okay, what is stage 1A, 1B, 1C? All of that you should be knowing. Then you should be knowing what molecular subtype that they have given. Then you should think, analyze that what risk stratification it will become, which color it will become, and what adjuvant treatment we follow. So everything comes from these 3 steps. So ultimately, we are doing all of this to guide us towards an adjuvant therapy, which is required for that patient or not, to reduce the recurrence and also to improve the survival benefits. So remember these pole mutants, which I have put it on the left side of the screen. So these are the subtypes. You have to remember it for next 10 to 15 minutes. Pole mutant, P53 abnormal, MMR deficiency, and then NSMP ER negative, NSMP ER positive. And remember the color coding as well. Okay, if it is green, naturally, it is a low risk. If it is yellow, it is an intermediate risk. If it is orange, then it is a high intermediate risk. If you have got red, obviously as it implies, it's a high risk. If something you're seeing in gray, then it is an uncertain risk classification or insufficient data. How to interpret this, we'll come to it later. Okay, can somebody tell me that what are those molecular subtypes you should be remembering now for the next discussion activity?
Pole mutation, P53 abnormal, MMRd, NSMP ER negative, and NSA
Yeah,
MMR positive.
non-specific ER negative, non-specific ER positive.
Positive.
Okay, and this is the color coding you should be remembering for the next 10 to 15 minutes to register everything. So first we determine the anatomical stage, whether it's an aggressive histological type, whether it's a grade 1, grade 2, grade 3, what is the anatomical stage? Does it come under 1A1, 1A2, 1A3? All that you should be knowing. Once you have that, then you determine the molecular subtype, that what molecular subtype that they have given. So as of now, we know that pole protects, which is excellent prognosis, and we know the MMR deficiency is still, we'll come to it later. And if ER negative is there in NSMP, then it's more aggressive, and P53 abnormality, definitely it is more aggressive. This much we know as of now. So now let's take one example. So who wants to be the volunteer? Yes? Dr. Kine? Kine, are you there?
Yes, doctor.
Yeah. So as of now, you followed all of this, right?
Yes.
Okay. So now we have got stage 1A1 cancer. What is it? Stage 1A1
Yes. Aggressive, limited to polyp
or endometrium,
endometrium.
right? Yeah, it's a
Yes.
low-grade cancer. It's a non-aggressive low-grade cancer, which is limited to the endometrium or polyp. So we won't be
Yes.
having any myometrial invasion. Agree?
Yes, doctor.
And then she has got a pole mutation. Okay, this is what they have given. So what is your interpretation when it comes to risk stratification? Just look at the graph here, I mean the chart here.
Yes.
So you have got
Yes.
no invasion, right? Confined to the
Yes.
polyp or endometrium. And all they are saying is that pole mutation is positive. Yeah. So what you can see here,
Yes, green color.
green color. So what exactly it means to you?
Low risk.
Low risk, correct. So this lady comes under low risk. She doesn't have any myometrial invasion. It's a low grade cancer. Just she has a pole mutation and it comes under low grade endometrial cancer. So basically it is a green risk stratification. So the next question to you is that do you need an adjuvant treatment for her? Do you recommend an adjuvant treatment for her?
No, doctor.
No, because she comes under low risk. We are not giving her any, or we are not discussing any adjuvant treatment. She'll just be under follow-up plan, but otherwise she doesn't require any adjuvant treatment. Clear?
Yes, doctor.
Okay. So the next volunteer, please. Go on. Come on, guys. Let's discuss little faster. Yeah, Dr. Bhuvi.
Yes, ma'am.
Yeah. So you have got stage 1A1. What is that? What does that mean?
Non-aggressive type confined only to the endometrium.
So no myometrial invasion.
No
Okay.
myometrial
And she
invasion.
has got MMR deficiency. So what does the chart say?
Um, it is green
The
in
same thing.
color, ma'am.
Yeah. And MMR deficiency. So it says it is 1A1 or 1C. Let's ignore the 1C now. It is 1A1. So there is no upstaging, nothing. MMR deficiency is there. Still, it is falling under what category?
Uh,
Risk. Yeah.
okay.
So
Okay,
because
ma'am.
it is green, so she's still falling under low risk category. So do you need an adjuvant treatment in here?
No, ma'am.
So she doesn't require any adjuvant treatment. So we discussed 1A1 with a pole mutation. We know it's an excellent prognosis. It's a low risk, no adjuvant treatment. Even MMR deficiency, it is still low risk cancer, no adjuvant treatment. So why they have given 1C in the bracket? Are they trying to say that MMR deficiency means it's 1C? What is it? No idea. So
Oh, ma'am.
basically, it is always 1A1 if there is no myometrial invasion. So think of like that. If it's 1A1, there is no myometrial invasion, it's always 1A1. But if at all, they say there are some additional pathological or molecular characteristics, then that may alter the classification. They've not given it could be a plus or minus. But as of now, you guys have to remember that MMR deficiency and there is no myometrial invasion, it's only 1A1, then naturally it is a low risk cancer, which is green. So no adjuvant treatment. Clear so far?
Yes, ma'am.
Okay. So who is the next volunteer? Dr. Soumya?
Yes, ma'am.
Yeah. So you have got stage 1A1, yeah, which is a non-aggressive histological type, limited to the endometrium or polyp, and there is no myometrial invasion. And it is NSMP low grade ER positive cancer.
Yes, ma'am.
So what does that mean to you?
It comes under low risk, ma'am, again.
So here you can see no myometrial invasion confined to the polyp or endometrium, and this is what is positive, which is NSMP low grade and estrogen receptor positive. So
Positive.
this is again green,
Green.
right? Yeah. So she will become low risk cancer. And do you need an adjuvant treatment here?
No need of adjuvant treatment, ma'am.
Yes. So there is no requirement for an adjuvant treatment. Brilliant. So the next, you can take the same question here. The same question, it becomes NSMP high grade, ER negative. So what does the chart say now?
Gray. It is
Gray.
gray. Yes, ma'am.
Yeah, gray. So what is gray? Non-specific. It is non-specific molecular typing. It's high grade and ER negative. All this itself is telling us that it is bad. Because when we have estrogen receptor positive, we have medications, we can treat it. We have got
Yes, ma'am.
systemic therapies. But when it is ER negative, it's very difficult to treat such cancers in the form of adjuvant therapy. Agree?
Yes, ma'am.
So they are saying NSMP high grade or estrogen receptor negative or both. But how is it possible to be having 1A1? That means the tumor is confined only to the endometrium or polyp. There's no myometrial invasion because as such, the molecular typing is saying it should be high grade or it should have had some spread beyond the endometrium. So something is not syncing.
Yes,
Something
ma'am.
is not in sync here. So they are putting it under gray zone.
Okay, ma'am.
Okay, it could be 1C also. We don't know. What is 1C? It's an aggressive histological type with myometrial invasion.
Invasion.
So here they are saying there is no myometrial invasion. It is only confined to the polyp or endometrium, very basic early cancer. But how is it possible to have a NSMP high grade estrogen receptor negative and have such a early cancer? So something is not matching. So such cancer, they put it under gray zone. That means it requires some more discussion with the MDT. They may subject the tissue once again for a mapping. You may
Okay, ma'am.
pick up some occult mets there. You may pick up some occult invasion into the the myometrium. That's why that comes under gray zone.
Gray.
Understood? So you have
Yes,
to tell the
ma'am.
same thing the patient that something is not matching in here. So that this requires a further MDT input. We may have to involve the tissue experts. We may have to re-look at the tissue samplings once again to rule out any occult met. Understood?
Yes, ma'am.
Okay. Next person. Same, the concept is being applicable here. Anyone who wants to take up? Dr. Fatima?
All right. I think in this case we've got P53 abnormality, so it's in the gray zone, and it needs further investigation to rule
Yeah.
out
Why?
more progression because of P53 abnormality and the gray zone.
Yeah. So we know naturally P53 abnormality warns us. It's a bad
Yeah,
prognosis. But she has a
definitely.
very early cancer limiting to only the polyp or endometrium. Something is not in sync. That is why we always subject them to the gray zone, and that requires a further MDT approach in here. Okay?
Dr.
Once,
Deepika, can I ask something?
yeah.
If this falls in the gray zone, can we tell while counseling the patient, what should we tell her? We should tell her that from the histology
So you need to
interpretation.
say that if she had a stage 1A1 cancer before the surgery, even after the surgery, you have to say that fortunately the histopathological diagnosis when we did the tissue sampling by the tissue experts, it turns out to be the same. Okay, draw her and show that it is limiting only to the inner lining of the womb. However, we have done the molecular typing to guide us whether this would tell us whether you require any additional treatment has come, and that has come positive for some high molecular typing. This means it shows some aggressive, behavior. Okay, so that has come positive. So when we have such conditions, we would like to rule out any the cancer which must have spread beyond the endometrium. So to rule it out, we subject your histopathological diagnosis once again to undergo one more testing by the tissue experts, and we discuss this with your team of specialist doctors. And if it turns out to be the same, I mean to say there's no myometrial invasion, then she doesn't require any treatment. She'll come under 1A1 only. But if we find out any myometrial invasion, then she would require further treatment in the form of radiotherapy or chemotherapy.
Thank you.
Okay.
Thank you so much. Thank you.
Yes. Okay, so now you understood this, right? Why we have put this NSMP, the non-specific high grade or estrogen receptor negative, and P53 abnormality into gray zone is that we are missing out something in here, because these are a very aggressive molecular typing, but then we are seeing only the cancer limiting to the endometrium. So this is something which we are not expecting when we have such molecular typing. That's why we subject them for further MDT and further histopathological diagnosis to put it under 1A1 or whether it has to become 1C. All right. So this is the 1A1, the summary in a nutshell, that if you have got 1A1, which is the tumor which is limiting to the endometrium or a polyp and there is no myometrial invasion, you have got a pole mutation, thumbs up. If you have got MMRd, thumbs up. If you have got NSMP low grade ER positive, thumbs up. She comes under very low risk and she doesn't require any adjuvant treatment. However, if she has got a high grade or a ER negative cancers or a P53 abnormality, we don't know. We cannot comment. This requires a further classification. So this requires a final risk allocation. So just refer them to the MDT and tissue experts. Okay, I hope everybody is clear with stage 1A1 cancer. So I want one of you as a volunteer now to take up the next activity. Dr. Maria? Okay, Dr.
Okay.
Yeah,
Okay, ma'am.
Dr. Maria. So now you look at stage 1A2. What is 1A2?
More than half of the myometrium?
1A2 is still less than half of the myometrium involvement. Okay?
Okay.
You can see here. So the myometrial invasion is less than 50%. So this is 50% involvement is there. So in this case, there is a pole mutation present. Okay? So what will be the risk group of hers?
It comes in green, low risk, ma'am.
Yeah, so she comes under green. So this
Yeah.
is low risk. So she doesn't require,
Radiotherapy, adjuvant
she doesn't
therapy.
require any adjuvant treatment. So similarly,
Yeah.
look at the same 1A2, which is less than 50% myometrial invasion, but it is MMR deficiency. Okay, what does it say here?
Again, it comes in a green and
As
less
of
than.
now, you remember it is green. It is still green. Okay.
Yeah.
What about NSMP low grade estrogen receptor positive status? When it is low grade, when it is estrogen receptor positive, think it is always good to some extent. Okay. So what is it? It is still under green.
Green.
So it's almost
Right.
similar to 1A1. Okay, when you have a
1A1.
pole mutation, when you have a MMRd deficiency, when you have got non-specific low-grade estrogen receptor positive, almost it is similar. It is green, which is low risk, and no adjuvant treatment is really required in here. But afterwards, what
Right.
has happened to the color coding? There is this NSMP non-specific high-grade or estrogen receptor negative or P53 abnormality. What is happening with the color coding?
It's red color, so high grade.
Yeah. So the moment there is a myometrial invasion and on the background you have got a higher molecular typing, yes, it comes under high risk, and she would require an adjuvant treatment in the form of chemotherapy and radiotherapy. Understood? We are talking about
Right.
P53 abnormality, not the wild type. Wild type is considered as normal. Okay? P53 abnormality. So it's almost similar. So when it comes to 1A1, 1A2, or 1A3, this would remain the same, which is pole mutation, MMRd deficiency, or non-specific low-grade estrogen receptor positive. Almost they all come under green zone, and we don't require any adjuvant treatment because they're all low risk. But the moment you see any myometrial invasion, and on the background you have got NSMP high grade or estrogen receptor negative or P53 abnormality present, they all become red. So the moment there is a myometrial invasion, these things will fall under, the red, which is high
Right.
risk. Okay. So
Yes.
just give me a minute. Yeah. So you can see here, the same thing I have put it here. I did not make different slides. So pole mutation, MMRd deficiency, NSMP low grade ER positive. So they all come under low risk if it is stage 1A2, which is less than 50% of myometrial invasion. Whereas high grade or ER negative or P53 abnormality, they come under high risk. So naturally they require chemotherapy and radiotherapy. So now I would like to give you a outlook of how this 1B looks like. So this
Excuse
is
me, Dr.
what,
Deepika.
yes.
If there's mention of any terminology except for like the mutation or a P53 abnormality, is it all low grade, like molecular classification?
P53
Like,
abnormality, P53 mutation, they are all high risk, dear. They are all aggressive
no, if
pathology.
they mention, like they mentioned on the wild type or,
Huh?
any other terminology, that means it's not
Yeah, it is not. Yeah.
aggressive.
There are only
Oh,
these two things that you need to remember. Either they give it as
okay.
wild type P53 or they give it as P53, which is, abnormal. Okay. These are the
Okay,
only two
thank
things
you.
that you need to remember. Yeah. So now let's look at the myo invasion is more than 50% involved, and it is still a non-aggressive histological type that comes under 1B. Okay. But if you look at the pole mutation is almost green. If you see your stage 1, if you look at stage 2, the pole mutation is almost green. It is favoring the prognosis. They don't require any of the adjuvant treatment. Whereas MMR deficiency, it is green unless it is less than 50% of myometrial invasion. You can still consider it as a low risk and she doesn't require any of the adjuvant treatment, and same thing is applicable. So almost MMR deficiency and NSMP low grade behave the same way. But afterwards, the MMR deficiency or NSMP low grade, we have to give some importance in here because they become intermediate risk. The moment you see more than 50% myometrial invasion, which is 1B, and you have got MMR deficiency or you have got NSMP low grade, even they become intermediate risk. They are no longer low risk. They come under yellow category. So they require vaginal brachytherapy. That's it. No chemo, no EBRT, nothing. They just require vaginal brachytherapy. Remember to kind of play with this, understand the sequence, because they generally are going to ask you in stage 1 and stage 2 only. Because in stage 3 onwards, the treatment is obviously the cytoreductive surgery if they are amenable, if they have got, if they don't have any comobs. Otherwise, you have to go with chemo, radio, or a systemic therapy. So naturally, they try to play with these stage 1 and stage 2, and most of the times stage 1A and 1B only. So please remember these things. So the moment you see more than 50% myometrial invasion and you have got MMR deficiency or NSMP low grade, they become intermediate and you have to go for vaginal brachytherapy. And other things are anyways high risk, which I have already told. The NSMP high grade, P53 abnormality, there's no question. They are always a very aggressive molecular typing. So they always require a chemotherapy and radiotherapy, a combination of these. Understood? Everyone? Any questions
Yes,
so
ma'am.
far?
Yeah.
So this is the thing that you need to remember, that be it 1A1 1A2 or 1A3 for that matter, and 1B where there is a myometrial invasion and you have got pole mutation, which is basically a low risk, low risk, low risk. Pole mutation is good up till even stage 2 cancer for that matter. Okay, but MMR deficiency only for 1A1 and 1A2, which is a low risk. The moment you see more than 50% myometrial invasion, it becomes intermediate and that requires vaginal brachy. And same thing is applicable even for your NSMP low grade ER positive. NSMP high grade and P53 abnormality is only gray only when the tumor they are saying very early, because that is not the case we generally see in these type of molecular typing. That's why this requires a further MDT opinion. But otherwise from that 1A2 onwards, they're all high risk and they require chemoradiation. Please take a picture of this and understand. You do it yourself. Once again, this activity, you yourself will understand this better. Okay, clear so far? Everyone?
Clear, ma'am.
Perfect. So pole always protects. Pole always protects up till your stage 2 cancers. After that, we don't know. After that, it's a gray zone we have to discuss. But for stage 1 and stage 2 cancers, it has got a favorable prognosis. She comes under a low risk. She doesn't require any adjuvant treatment at all. Okay. So even for that matter, cervical stromal invasion also I have put it up that, the pole is always protect. It's a low risk MMR deficiency. So even if you don't remember after this, it's fine, because any of this which comes, which is positive after this except pole mutation would require some adjuvant treatment. So even in the exam, if you don't remember whether it's whether it is orange or yellow or red or what is it, don't bother. She would require adjuvant treatment. So you can put it in a gray area if you're not sure whether it is a EBRT, whether it is a chemotherapy or radiotherapy. Just put it that we may require radiotherapy or a chemotherapy or a combination of those. That will be discussed with a team of specialist doctors, because that's all you can remember in the exam in that stress. Okay, after this onwards, everything would require some form of adjuvant treatment in the stage 2 cancer, except your pole mutation. Okay, clear?
Yes, ma'am.
So if you look at this complete chart, which I have given here, so look at this local spread or regional spread or both. That means they're trying to say that it's a stage 3 cancer, right? So in this stage 3 cancer, everything is almost becoming red in here. Okay, or a gray in here. So everything requires some form of, adjuvant treatment. That's why they're not going to check your understanding in here. They always give stage 1 or stage 2, because that is where is the confusion for most of the students, whether the adjuvant treatment is required or not. So that is why they don't check for stage 3 or stage 4 cancers. Most of the times they check for stage 1 and stage 2 cancer, where the adjuvant treatment differs, whether it's a vaginal brachy or EBRT or it is both. So always remember the stage 1 and 2 very well, so that you guys can tackle the station really well. So that is something that you guys have to remember. So when it comes to low risk, most of the times we don't require any adjuvant treatment in here. Whereas in intermediate risk, either we can offer them the vaginal brachytherapy or no adjuvant therapy. This is based on what? If she's like less than 60 years of age and she's very low grade cancers, there's not much of invasion or anything like that, you can offer them no adjuvant therapy, but that is at the discretion of MDT again. Otherwise it's a vaginal brachytherapy. If it is high intermediate risk, then we can go with external beam radiotherapy with or without vaginal brachy. Okay, if it is high risk, then they would require both radiotherapy as well as chemotherapy, or if they are not fit for it, then they can go with the systemic therapies as well. Like we have got immune checkpoint inhibitors and things like that. Okay, understood? So as of now, intermediate risk are only two things here, which is like stage 1A2 MMR deficiency or stage 1A2 non-specific low grade or estrogen receptor positive. If only these two are there, that would come under intermediate risk, and rest of the things would require, would come under high intermediate or high risk. Any questions, guys? No questions? Clear? Is it overwhelming? Please answer. Zabe? Dr. Bhuvaneshwari?
Yes, ma'am. Clear, ma'am.
Okay, Dr. Zabe? Clear. Okay, perfect. So in the intermediate risk, only if she's like less than 60 years, very young, low-grade tumors, you can still discuss the option of no treatment at all. But otherwise, we go with, in the form of brachytherapy. Okay, so this is the nutshell. I mean, these are the points that I have put it in nutshell. If you just so read it, you will not understand it. Okay, but if you have followed the lecture so far, definitely you would understand what I was trying to tell. Okay, in case of stage 1, like 1A1, 1A2, 1A3, and 1B, if it's a pole mutation, of course, she doesn't require any adjuvant treatment, and stage 2 where 2A and 2B is there. And I'm not talking about aggressive histological type. I'm not talking about 2C or 1C. Okay, that you need to remember. It has to be a low-grade cancers. And you have got pole mutation. Of course, it has got low risk and no adjuvant treatment is really required. And if you have got MMRd deficiency and you have got stage 2 cancer, sorry, stage 1A1, 1A2, 1A3, which is less than 50% myometrial invasion, again low risk. But in MMR deficiency, the moment you see it is more than 50% myometrial invasion, which is 1B, then she will come under intermediate risk, and she would require a vaginal brachytherapy. Okay. And if you have got MMR deficiency in stage 2A, which is cervical stromal invasion, okay, then you would require EBRT because she comes under high intermediate risk because the risk increases afterwards. NSMP low grade also behave exactly similar to the MMR deficiency. P53 abnormalities, again, 1A1 is uncertain because we expect it to be more advanced. So that's why we discuss this with the MDT and do further histopathological diagnosis. And if it still remains the same and there's no myometrial invasion, then usually no treatment required. But after that, every other cancer with a P53 will require chemo and radiotherapy here. Okay, so this is just the things in a nutshell that I have put. So the final one-liner for you guys for the adjuvant therapy is that if she's a low risk, then she doesn't require any treatment. But if she is falling under intermediate risk, then she would require vaginal brachytherapy. If she is high to intermediate risk, then she would require external beam radiotherapy, even much more extensive radiotherapy. And high risk, we require both. Okay, chemo as well as radiotherapy. And MMR deficiency, we've got many trials going on. They respond really well to the immunotherapy medications like Zumabs, benralizumab or adalimumab, those drugs. So we can put them on the immunotherapy as well. If it is uncertain risk, then we have to individualize and discuss this with the MDT. So clear before we move on to the next concept? Yeah?
Yes, ma'am.
Okay, so there is the third key concept from here is that multiple classifier rules. So the similar situation, you may get the combination of the molecular typing. So we all know pole mutation protects, which is good. We know P53 mutation, which is a bad prognosis. We know ER negative non-specific ones is a poor prognosis again. So we know all of this. MMR deficiency, again, it depends on how much is the myometrial invasion, grade and everything. But they give two things there in the exam, that she is positive for pole as well. She is positive for P53 mutation as well. So how do you want to go about it? Always take which has got an excellent prognosis. That's the rule number 1 here. Say, for example, you have got a pole mutation and a P53 abnormality. Okay, how do you want to interpret this? Which is the final molecular classification you're going to give, which is pole mutant. We are ignoring P53 because pole is still dominates. Pole has got excellent prognosis that overrides your P53 abnormality. Similarly, you have got MMR deficiency, P53 abnormality. In out of these two, which is good? Yeah, Bhuvi, which is good? MMR deficiency and P53 abnormality.
MMRd, ma'am.
Yeah, so MMRd is better than P53 abnormality, which has got better prognosis. So we classify it as MMR deficiency. Pole mutation and MMRd. Again, limited evidence. Why? Because pole mutation is good, which has got excellent prognosis, but on the background, she also has got MMRd. We cannot rule out a Lynch syndrome here. So that is why do the Lynch syndrome, screening, and after that you can allocate it to the pole mutation. Clear? Everyone? Clear, guys?
Yeah, ma'am, it's clear, but I have one question. In pole mutation and the P53 abnormality is there, so why don't we take it as an aggressive type? Because P53 is abnormal. Still, we are taking it as classified as a
Yeah,
pole mutation.
so that's the paradox here. They are putting the pole mutant as superior here. Even though both exist, they're thinking the pole mutation overrides the P53 abnormality. It still has got an excellent prognosis because the pole protects, going through further invasion and node mets and recurrence. This is what they have understood from the studies. Okay, it's just the behavioral pattern they have understood, and that's why they have classified it as similar way. They're not taking it as a high grade ones, they're taking it as a low grade ones. Okay, so
Okay.
there's no particular reason why. This is that they have understood it from the so many studies that they have done so far. Whichever had got both, they had actually a better prognosis than having had only P53 abnormality. So they understood that P53 actually protects and it overrides P53 abnormality. Okay, always take
Okay.
a good one there, as simple as that, whenever you get two things. Okay, so even in the same task which we discussed just some time back, if she had a P53 abnormality, not P53 wild type, P53 abnormal and MMR deficiency, so how did you, how you would have discussed and counseled the patient there?
We will take the MMR as a
Yeah,
dominant.
yes.
Yeah. So
So
it
she'll come
it
under
comes
intermediate risk. She'll come under
intermediate.
intermediate risk, not a high risk, right?
Yeah.
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 So that's how it works here. So they have understood it from the basically different studies, and they understood that it overrides the high grade molecular typing there, as simple as that. So always remember the pole mutation, it's always a paradox. So wherever you see in the stage 1 and 2 cancers, not in 1C and 2C, where you have aggressive, it has to be a low grade. It has to be low grade. So 1A1, 1A2, 1A3, and 1B, and then your 2A cancers and 2B cancers. So in all of that, wherever you see the pole mutation, it's always, it can appear as a high grade histologically, but it is actually has got an excellent prognosis. So irrespective of the grade, it has got an excellent prognosis. Okay, and even they say that pole mutation overrides your high grade molecular typing in multiple classifiers. So if you have got both P53 pole mutant and pole mutant and P53 abnormality, always classify it as pole mutant. Okay, and in MMR deficiency, important point you should remember is that they respond well to the immune checkpoint inhibitors. And if you have got both MMR deficiency and P53 abnormality, always classify them as MMR deficiency. And P53 abnormality, it's very aggressive. They require intensified adjuvant therapy. That means intensified means they require both chemotherapy as well as radiotherapy. And non-specific, this we know that it depends entirely on the grade. It depends entirely on the estrogen receptor. If ER negative tumors means they always behave very, very aggressively. Okay, so clear up till now? So wherever you
Yeah.
have got pole mutation, so you have got pole mutation and P53, but still she's having like stage 1A cancers or something, 1A1 cancer. So you don't require any adjuvant treatment just because she's P53 mutation. So it de-escalate the adjuvant treatment. So you don't, because why are we so worried that what is the big deal? Give them the vaginal brachytherapy, give them the EBRT, give them chemo radio. Why? Because this all unnecessarily, put them, it basically it increases the morbidity of the patient. So dual treatment is always bad. It does more harm to the patient. That's why we are carefully weighing it, whether they truly require the adjuvant treatment or not. So if pole mutant is there, It naturally de-escalate the adjuvant treatment because she has got an excellent prognosis. We don't require any adjuvant treatment in here. That is something important in here. So, so remember P53 wild type is actually green, which means it's good. You don't have to worry about it. And P53 abnormal is something that you have to give importance to. And if they say the molecular typing is not known, okay, but when they say it is unknown, we don't know whether it's pole mutant, P53 or MMR deficiency or NSMP. We don't know any of these. We still classify the grade 3 endometrial or endometrial cancer as aggressive histology because we don't know what could be the underlying molecular typing here. The wild type is it's the normal variant of P53. Okay, save. So it is just the normal variant of P53. So P53 is always that, the DNA checkpoints, all of that is something that we look into, right? So if P53 wild type, if they're mentioning, it's just that normal variant of P53. So there is nothing abnormal there. You don't have to, it's just a normal expression. Yes, it's a normal expression of P53. Yes. So just before, all of you are clear about the molecular typing? Yes?
Yes, ma'am.
Okay, perfect. So the treatment, I will just give a quick, information in here. You don't have to go into too much details that how exactly we are going to do the surgery and things like that. If it is stage 1 and 2, stage 2 means where we have got aggressive or non-aggressive histological types where it is limited to the cervical stroma or some myometrial invasion or substantial infovascular stromal invasion. If they have given this much, up till stage 1 and 2, we are going to offer them the total hysterectomy with a bilateral salpingo oophorectomy, and it is done as a laparoscopic surgery, okay, minimally invasive surgery. So it has to be a total laparoscopic hysterectomy with bilateral salpingo oophorectomy with lymph node staging. Don't write it as, or don't say it as lymph node dissection, or don't say it as lymphadenectomy. It is only lymph node assessment. We palpate and see if there are any lymph nodes are bulky, then only we remove it. Otherwise, we are not going to touch it. And sentinel lymph node biopsy we are going to do for everything. So we inject that indocyanine green dye and then we assess. And if anything is positive, then we take that and go for ultra staging and all. Sentinel lymph node biopsy is there. But lymphadenectomy we don't do. And it's only the lymph node staging, lymph node assessment to be told in specific. And omentectomy, are we going to do it for everybody? No. Omentectomy is only if you have got aggressive histological types like serous or carcinosarcomas or undifferentiated tumors, then only you are going to do the omentectomy. And are we going to remove the ovaries for everybody? You can still consider leaving them behind if they are like age of less than 45 years, they are premenopausal and age is less than 45 years of age, and they have got very limited cancers like 1A1, 1A2, and they have got low molecular typing, then you can still go for ovarian conservation. In that only you can remove both the tubes, but take the history properly. If they've got any family history of ovarian or any Lynch syndrome cancers, BRCA mutations, strong family history of cancers, then you cannot advise any ovarian conservation in them. Okay, otherwise it has to be a total laparoscopic hysterectomy with bilateral salpingo oophorectomy with lymph node assessment with sentinel lymph node biopsy. This is the standard one we are going to do for early endometrial cancer, which is basically your stage 1 and stage 2 cancer. Okay, clear? Yes. For stage 1 and 2 cancers, but if they are medically unfit, they've got a lot of comorbidities, they are not fit for surgery, then you can go for vaginal hysterectomy with bilateral salpingo oophorectomy if they are fit for at least undergoing this surgery. If they cannot undergo even the hysterectomy, be it as abdominal or a vaginal hysterectomy, then the next option would be to go for radiotherapy. Okay, that's all you have to remember. You don't have to go into the details. Okay, so if you can do vaginal hysterectomy, do. If not, go for radiotherapy. For stage 3 and stage 4 cancer, if they are medically fit, go for cytoreductive surgery. Try and remove how much ever you can. macroscopically, how much ever the disease is there, try to resect all of that. And if any lymph nodes which are suspicious for you, you can do that also. Again, even in stage 3 and stage 4, lymphadenectomy is not recommended. Only the suspicious lymph nodes, because it just increases the morbidity. If you remove so much of lymph nodes, the people will end up with lymphedema and things like that. So only if lymph nodes are enlarged and they look suspicious, then only you're going to remove that. So cytoreductive surgery is the first thing. But if they are not fit, okay, if they're not fit for the surgery, then you have to go for radiotherapy with or without systemic therapy. Okay, so always for stage 3 and stage 4 cancer, we always discuss with the MDT before we go with any type of treatment in there. Okay, and where do we suspect the Lynch syndrome? Wherever we have got MMR deficiency, which is mismatch repair deficiency. Sometimes they give MMRd, but for part 2, they give it as MLH1, MSH2, MSH6, PMS2. If these things, if they say like there's a loss of these molecular typing, then yes, you have to screen for Lynch syndrome. And if she comes positive for that, then the familial, whoever is the relatives, the sons, daughters, they also should undergo testing in that. Okay. Any questions from anyone? Any question, guys?
Dr. Deepika, while doing the vaginal hysterectomy in a patient who is not fit, do we need to take some lymph node sampling or not? I'm not sure about
In the first one, you can do the you can do the laparoscopy, and you can do the sentinel lymph node assessment on all of that. You can definitely do it. That's not an issue. Okay, but they can tolerate that much. If you again, this will be discussed with MDT anesthetist if she's fit to undergo that much, because if she's undergoing vaginal hysterectomy, I feel that she can at least tolerate half an hour of laparoscopy, so they can go for lymph node assessment. But otherwise, it's only a vaginal hysterectomy and bilateral scalping oophorectomy, and they may consider giving adjuvant treatment later. Okay.
that. Thank you. Thank you.
Yeah. Any question from anyone? Understood, everyone? Did I make it clear? Was it easy to go through, or is it too overwhelming?
It was not easy at all. It was too much for us. I've never come across such an extensive molecular sort of
Yeah. The reason
assessment.
why we started discussing this is that unfortunately this has appeared in the exams these days, and people were not able to decode it. That what is intermediate risk, what is low risk, and where are we giving this adjuvant treatment or not. So I took a lot of time in decoding this and presenting to you guys in a simple manner, so that if you guys read it, it will become very easy. But if you yourself go through the guidelines, you will not understand any of this. That's why I told the topic also beforehand, so that you guys will go through it once again. But FIGO 2023 doesn't discuss in detail any of this. It has highlighted more on the staging. Even the molecular typing, it has not given so much in detail. So this we have taken from the ESGO guidelines, the European guidelines. But this has appeared in the recent exam, and it's important that the exam pattern is changing, and it's important that you guys should be aware. But remember that the pole mutation for stage 1 and stage 2 cancer, it has got an excellent prognosis. Okay, and they come under low risk, and you don't require any adjuvant treatment. Whereas MMR deficiency, as long as it is limited to the endometrium, or it is less than 50% of myometrial invasion, which is 1A1 and 1A2, it has still got a low risk category. You don't require any adjuvant treatment there. The moment it is saying more than 50% myometrial invasion, which is basically your 1B, and there is MMR deficiency, that puts them under intermediate risk, and they would require a brachytherapy there. Okay, from there onwards, any MMR deficiency would become, the candidate would become eligible for adjuvant treatment there. Except 1A1, your NSMP high grade ER negative and P53 abnormality except 1A1, any stage you get, they would require adjuvant treatment in the form of chemotherapy, radiotherapy. At least this much you can remember now.
That's very precise. I've got a suggestion. If you could just have weekly things in which we can have these recent recalls. I think that would be a great help. So how the exam is
Sorry, come
evolving,
again,
then
dear.
yeah, I'm suggesting that if you could have weekly meetings in which the recent recalls are there, like you go through recent recalls like this one.
Yeah. So we always discuss the recent recalls, the recalls which are being repeated most of the times, which